the second-degree atrioventricular block or second-degree heart block. Anytime you see a P wave that is not followed by a QRS complex, there's an indication of an advanced type of atrioventricular block known as either second-degree or a third-degree heart block. This becomes the hallmark for identification of these heart blocks. Anytime you have a P wave that is not followed by a QRS complex, you automatically know this is not a first degree heart block. It is either a second or a third degree heart block. There are two types of second degree heart blocks, and their mechanism as well as implications are different from each other in as much as they're known as second degree heart block. Another term that we use to distinguish these two types is Mobitz I and Mobitz II. Let's start with the first one, the Mobitz I second degree heart block or Wenckebach. In this type of heart block, the mechanism of conduction disturbance is related to the structural abnormality of the atrioventricular node itself. So, there is a gradual prolongation of the PR interval that leads to a non-conducted PR interval. In short, the P wave is not followed by the QRS complex following the longest PR interval sequence. Let's suppose of this analogy to help you understand better on the Mobitz Type I. Assume that you have an assistant who you sent to buy a drink from a store that is a half a block away. It might take that person 10 minutes to go and return with the drink. However, if you add another request, maybe to go and buy a bag of chips, being a good assistant, they will return to the store again. However, at this time, they will return slightly longer time. They will take a slightly longer time for them to return, which is approximately like 15 minutes, longer than what they took in the first round. On his return again, you ask him to buy a chocolate from the same store. At this point, they're tired, and it may take them even longer to return, perhaps 18 minutes. Then as soon as he returns, you ask them to return again. This time they may refuse and flatly say no, because they're tired. Now let's apply to this Mobitz I. So in the second degree Mobitz I type of heart block, the P waves are not followed by QRS complex, and in examining the PR interval, there is a pattern of prolongation until there is a P wave that falls and fails to be conducted. The PR interval keeps on elongating until there is a failure of a P wave to be conducted. Some of the characteristics of a Mobitz I or a second degree heart block type 1 is the ventricular rate may be slow, normal, or fast, and arterial rate is within the normal range. Remember, we're just having an AV node issue here. In terms of regularity, there is an irregularity in the rhythm, and the P waves are present and normal. However, not all of them are followed by the QRS complex. The QRS complex is normal in this case, and the PR interval is the one that progressively becomes longer until the QRS complex is dropped, and then the cycle again repeats again. The QT interval is usually within normal limits. Let's look at the implications, causes, and treatment of the second degree heart block. The AV node becomes progressively slower over time in conducting the cardiac impulses until such a time that it's no longer able to conduct any impulses to the ventricle. This type of heart block is a transient rhythm that is not considered as a serious rhythm and resolves spontaneously. And for you to understand better, as we said earlier, the pathology of this type of heart block is located in the atrioventricular node, and therefore the normal conduction to the bundle branches results in the presence of a normal QRS complex that has a normal duration and normal structure. It is usually caused by ischemia to the cardiac muscles, an increased vagal tone, or some medications, for example, digitalis, beta blockers, and some cases of hyperkalemia. So whenever you're asked about the consequences of hyperkalemia in patients, we could be able to see a Mobitz 1. When a patient has a second-degree heart block and they are symptomatic, which is usually they may be associated with issues of bradycardia, we may treat this one with atropine or dopamine or a external transthoracic pacing. So let's move to the second type of second-degree atrioventricular block, known as the classical heart block, or Mobitz Type II. In this type of heart block, the pathology is in the band of His and the Purkinje system. This is quite a serious type of block, which has a potential to progress to even a complete heart block, which is a third-degree heart block, and even a systole when the heart stops beating. The type is usually managed through an insertion of a pacemaker. In this case, there are P waves that are not followed by a QRS complex. You remember what we said, the hallmark of second and third degree atrioventricular blocks? The P waves which are not followed by a QRS complex. And it differs from type 1 or Mobitz type 1 in a way that the PR intervals here are consistent. You remember in Mobitz type 1, we have a continuous prolongation of the PR interval. And in this type, in the Mobitz 2, we have all P waves which results in a QRS complex and are conducted in a consistent time duration. Therefore, we can say we have fixed or identical PR intervals, right? This one is a serious arrhythmia which may progress to a complete heart block or a systole, like we've said, and we always need an emergency pacemaker to manage this type of patients. It is usually caused by a myocardial infarction, particularly which happens to the anterior wall, or a degeneration in the conduction system of the heart. Some symptoms which may be associated with this type of a block are like bradycardias and a decreased cardiac output. And whenever we have a patient with suspected or confirmed second-degree heart block, we manage it with an insertion of a pacemaker and the use of vasopressors to support the heart rate and the blood pressure. Some of the characteristics of these type of block is that the rhythm can be either regular or irregular, and the heart rate is usually slow with features of bradycardia. And we may be having 2, 3, or 4 P waves before each QRS complex, and these are usually identical in terms of duration.